Chapter 3 covers other tests that they have available. Of course, you have your static lung test. Okay. Static lung tests are things like your spirometer. Remember, a spirometer has limitations in it. It only measures what you actually are breathing, so it doesn't measure residual volume. So because it can't measure residual volume, you cannot obtain your FRC out of it. So that's not a good thing. One of the things that if you want to get residual volume, then you have to use a body plethysmogram, or you want to use a helium dilution test. Both these will give you FRC, and they'll also give you total lung capacity, which is, again, not available with a normal spirometer. Okay? The helium dilution test, the limitation on it is that the helium, for it to get to the space to measure it, it must be open to the environment. It must be open to the atmosphere. So if you have a collapsed portion of the lung that's behind a bronchus that's collapsed, then with a helium dilution test you will not pick it up. You can pick it up with the body plethysmogram, but you will not be able to pick it up with a helium dilution test. So that's a significant limitation on it. This is, of course, your body plethysmogram. It's something you're not going to be carrying in your backpack, so something that's not very useful in the sense of in the operating room. But it is requires a specialized lab to do. Usually the pulmonologists have these kind of labs in place. The body plethysmogram, what it basically does is it has a shutter. What the individual does is takes normal breaths, and the person is told to take a big, deep breath, okay, and then the shutter will close right when they're starting to take the maximal effort. And as a consequence, just the actual volume inside the chest begins to change, but not the volume, but rather the pressure begins to change, and that causes that measurement of the ability to figure out your residual volume and everything else. Okay. Helium dilution test, on the other hand, requires that you get a helium amount that's given to the patient, and then is measured accurately. So if you have any break in the mouth with the tube, you will actually get a failure in the test. You can also fake the test. If you breathe into your nose, you can dilute out the helium. So there's different ways that people can actually defeat the test and give you abnormal values. Most of the time what they do is they'll pinch the nose with the device, so you can't really do that, but still, you have to perfectly seal your mouth around the mouthpiece for it to give you an accurate measurement. Static lung tests give you an increase in air resistance, leads to an increase in FRC, okay, an increase in residual volume. When you see patients that present with reduced lung compliance, this leads to a decrease in FRC and decrease in residual volume. And that's kind of important for you to know, in the sense that reduction in lung compliance, it means that that person is shifting down their compliance curve. Okay? And that means that that person has an inability to breathe at the portion of the curve that instead of, let's see if I can show you here. Okay, instead of being here, when that person takes in a change in pressure, they get a large change in volume. What you see with a reduced lung compliance, this will actually shift downwards to a more flatter portion, and these people now are starting here, and as a consequence, you get almost no change in volume. So that person becomes ineffective in their tidal volume. So the way they're able to make up for that is they don't breathe deeper, they actually breathe shallower and breathe faster. Okay? Because minute ventilation is two things, respiratory rate and tidal volume. But you will notice that if you're doing your static lung test, you'll see a decrease in FRC and a decrease in your residual volume. Okay? Plethysmogram measures all volumes in the lung, except for residual volume. Okay? Your body plethysmogram measures all the volumes in the lung, which is correct. Okay? Your spirometry is the only one that measures all the ones that your expiratory reserve volume, inspiratory reserve volume, and your tidal volume is the only thing it measures. Helium dilution test only measures those volumes that communicate to the mouth. So whatever is not communicating to the mouth, you will be fooled by. So consolidation or tumors impinging on a bronchiole will cause the helium dilution test to be abnormal, look normal, but it's not. Now, the other test that can be done is by measuring what's called lung elasticity. This can be done using pressure volume loops. It basically, interpretation-wise, you can look at the elastic recoil if it's reduced or increased. In a person who has a reduced elastic recoil, that means that the person has lost the actual elastin molecules that are inside the lung. And the only thing that really does that is something that destroys the lung, so like emphysema. People that have asthma sometimes will get this as well, but they usually have to have very extensive disease where they've got infection that's causing fibrosis and eventual damage to the lung. The initial fibrosis component will actually increase the elastic recoil initially. So if you replace elastin with collagen, that's very bad because it makes the lungs stiffer. And as a consequence, elastic recoil is actually increased for that individual. That's what we call interstitial fibrosis. If you fill the alveoli membrane with water, okay, or in the interstitial space with water, you make the lungs stiffer as well, instead of being with that. But the good thing about that is that a lot of times that's reversible. If you can remove the fluid out of the interstitial space in the alveolar edema, it goes away. It's the more concerning part of increasing fibroblast formation inside the interstitial space, which then causes collagen deposition that causes permanent elastic recoil increases and causing damage. Okay? Remember, elastic recoil is reverse to compliance. Compliance is what we use normally. Okay? So when people talk about elastic recoil, they're talking about how much elastin or how much collagen is in the tissue. If you're talking about compliance, it's a reverse concept of how willing is the lung to distend. Okay, so if you have a person with an increased elastic recoil, they would have a decreased in compliance, and that's what catches students. Hint, hint. Okay, make sure you understand the difference. Okay, this is a compliance curve. The compliance curve in green is what we normally see in a textbook. That green line is made up of two different compliances, okay, the thoracic compliance and the lung compliance. Okay, the thoracic compliance is, of course, the ribs that are trying to come out at all times, and the lung compliance in the red line is the lung trying to collapse inwards. The green line is the actual total compliance line that's made up of these two not static conditions. Okay. If I change one compliance, it'll shift the overall green curve. In other words, let's say if I make somebody's lung compliance decrease their lung compliance. Let's say I make their lung heavier with water. The way you want to think about this is just take this line and put weights on it, on this end. Add more weights. Okay, and when that does that, it then makes the line come out this way. It flattens it out. Well, what happens to the green line? The green line then follows it. Okay, and that's a reduction in compliance, in lung compliance. So anything that makes the lung either heavier or not want to distend, okay, which is like collagen deposition, interstitial fibrosis, things like that, it'll reduce my overall total compliance. On the other hand, if I let go of the elastic, okay, which is I cause emphysematous changes to an individual, okay, the lung itself now begins to elevate like this. Okay, it becomes higher, okay, which means this is shifting this way, which makes then the green line become more like the thoracic compliance line. Now, why is that important? Well, if you're becoming more like the thoracic line, then the chest wall is going to get bigger. The lung is actually inflating. But the point is that your start point is still right here. Somewhere in line, this is the start point. So if you actually put it in the wrong line, put it right here. If I make this person drop their compliance and make it decrease, then my new set point is going to get, for the same pressure, change in pressure, a lower volume. This individual under normal circumstances would do something like this, give you a large volume. Okay? But look what happens now. The new set point's up here now, this individual. Still in the same line, okay? So what you see in this individual, you're going to see, for the same change in 10, you're going to get a very low level of volume. So both ways are bad. Okay? If you reduce compliance or you increase compliance of the total lung, there are bad places to be. Okay? If you have a reduction in compliance, which is from pulmonary edema, interstitial fibrosis, then that person has to breathe fast and shallow. If, on the other hand, you have a person with hyperinflated lungs, they also will do the same thing. They'll breathe shallow and breathe fast. Okay? All right, so this is a normal FRC curve. So I'm trying to show you here, and they switch it over. This is a person with low lung compliance. Okay, and what you'll see is their total compliance is significantly diminished. Okay, and your inspiratory capacity has become limited in this individual. If you have the increased thoracic compliance, this is the reverse of what I was just showing you. Okay, this is a person with bad COPD, emphysematous changes. Again, you'll see that the new point, the starting point's up here in the top of the curve, so this person will breathe, again, a limited inspiratory capacity. Now, next way of measurement is airway resistance. Okay, it's a difference between alveolar to mouth over the flow rate. Okay, the interpretation is basically by looking at resistance. As you can see, increased resistance from chronic bronchitis, asthma, emphysema, and inhalational irritants. Anything that basically affects the bronchioles, okay, anything that constricts them down, makes them smaller, will increase resistance. Okay. Resistance, on the other hand, is normally decreased by increasing your lung volumes. Okay, so at certain points, when you get hyperinflation in the lung, you will get a decrease in resistance. Controlled ventilation, by far the most important ventilatory response method, is by CO2. Okay, and CO2 is indirect. Okay, CO2 is not a direct stimulant of respiratory response. Okay, most people get that wrong. It's indirect. The reason it's indirect is because it goes into the CSF and then it changes the pH. And the pH is what you're responding to. Not so much the CO2, but it's a pH change. Okay? Now, the reason you know this to be true is because they took a catheter and placed it inside of an animal's brain. Okay? And when they placed it in the animal's brain, then they infused a very low level of hydrochloric acid through this tubing. In other words, they changed the pH of the CSF. And immediately the animal began to hyperventilate. Within about 2 hours, the CO2 level was down to 4, and the animal was still breathing 40 times a minute. Okay, so the animal is not really caring about the CO2 anymore. It's only responding to pH. So really, the respiratory drive is pH dependent. CO2 is a secondary. It affects the pH by changing the CSF. That's why, if you think about this, it kind of makes sense after a while. If you hyperventilate somebody in the intensive care unit, within 6 to 8 hours after you hyperventilate that individual, their cerebral circulation normalizes again. And you have to ask yourself why. And the answer is that the CSF now has become more neutral again. Okay? Initially, when you blow off CO2, the brain will vasoconstrict. Okay? And then the pH will begin to slightly raise, come up. Okay? The person will become, slightly alkalotic if you're hyperventilating them. Okay? Well, give it time, and the person will waste bicarb out of the CSF and normalize that pH back to normal. And it takes 6 to 8 hours. So when you check your CO2 levels on your blood inside the CSF, it's normalized after 6 to 8 hours, and the vasospasm has gone away. The blood flow goes back up. The new set point has been established because the body tries to normalize the pH back in the brain as fast as it can. Make sense? Okay. Was there a ventilatory response to hypoxia? Yes, but in some people it's severely delayed. In some people it's actually almost absent. Okay, and if you give people anesthesia, forget about it. They're not going to respond to hypoxia. Okay, they're going to respond really to CO2 changes. Okay, this is a very interesting study done by the United States Navy. What they found was that some of their divers were really good at holding their breath for prolonged periods of time, and others were not. Okay, If you have a high hypoxia drive, that means you'll want to breathe when you desaturate. Others, they had some divers that didn't really seem to respond to oxygen as much. Now, who do you think of the people who are going to be a good diver, you think? You want the guy that doesn't respond to oxygen levels getting low. Because if your oxygen level gets really low and you respond, you'll try to breathe underwater, and that's pretty much fatal. Okay? So you want the guy that stays without that response. Now, where do you think those guys come from? Very good, high altitude guys. So people who are from Colorado, and all of a sudden you start seeing people there. You wonder, like, why is it people that I see that are from Colorado are Navy divers? That doesn't make sense. You would expect they'd never be exposed to the ocean before. What the heck, they're in the ocean, you know? But it's because they were at high altitude, and they're not as O2 sensitive. So, now do they wash you out just based on that study? No, they won't, okay? But they'll test you, and they'll actually forcibly drown you, okay? They actually will see you if you drown. Then they'll pull you out of the water and resuscitate you, you know. But they want to see that if you drown or not. Because then you know, if you're not scared of being drowned, then you're okay down there. You know, you're working by yourself, and you're also able to respond to when you're developing desaturation. And people can be taught to learn when their oxygen levels begin to fall and act. How dangerous is this? I'll tell you how dangerous it is. When I was a young man, I used to I got my lifeguard things and my badges and stuff like that, and then we were in a pool one time, and we were watching kids jump in the water. And we had one kid at the end of the pool that constantly hyperventilated. And then he would dive. He would go underneath the water, and he actually would do 2 to 3 laps on an Olympic-sized pool. This kid was underwater. This guy was an animal. Okay? And we used to watch him. And we thought, man, this kid's not going to do well one day. And we sort of, after a while, because he did it too many times. And then one day when I wasn't on duty, somebody else was that day, they were looking at the water and the kid was underneath completely unconscious. By the time they pulled him out, he was dead. Okay? So what happened was he was underwater, didn't develop the hypoxic response, there was no reason to breathe, and he hyperventilated himself so effectively down that his CO2 never got to the levels that he wanted to breathe, didn't get a warning, and then he went unconscious from hypoxia and died. So things like that can happen. So if you have your kids that you're teaching them to go underwater, you got to teach them, look, you know, you don't hyperventilate to the point that you're numb around your lips and then go underneath the water. Will you stay underwater a long time? Maybe permanent. Okay. So, but what actually makes you stop wanting to breathe is not oxygen, but actually CO2. Now, we used to prove this to ourselves. We would strap on. Please don't do this because then they'll think you're doing nitrous oxide on the floor or in the operating room. Make sure you're doing it with a bunch of people. So don't do this by yourself, this experiment, okay? But I'm telling you about it, but please don't do that because then you're getting all sorts of trouble. You put the oxygen mask on you. You strap it on. You go to 100% oxygen. Put a pulse oximeter on your finger, okay? And then tell yourself, I'm going to hold my breath. I can pretty much tell you within a minute and a half, all of you will be wanting to breathe, even though you're still 100% saturated. You'll be desperate for air in about 2.5 minutes. Okay, very few people will actually not be able to do that. But most people, about a minute and a half, they're starving for air. But their saturation is still 100%. You could be 100% FiO2 and you could suck in 100% oxygen, and still you'll be having this huge drive to breathe. The reason being is for every 4, when you're awake, the catecholamine release is 8 millimeter increase in CO2 per minute for the first minute, and after that's 4 per minute. Okay, so you know if you're going at 40 or 48 in the first minute, that's going to want you to want to breathe. In another minute, you'll be at up in the 50s. You'll definitely want to breathe at that point. You'll be pretty desperate. And even the pulse oximeter is still 100%, and you're doing okay, but you're just feeling you're not getting any more air in. That's a pretty important drive. Take the same experiment. Now you're watching your CO2. Hyperventilate yourself down to 22. Okay? It's really cool when you do it. You get dizzy, you know. You'll feel like you're going to go unconscious. Your saturation's 100%, but your CO2 is like 22. And you feel like your headache's going to explode because you're hyperventilating to the degree now that your blood flow is actually decreasing in your brain. So you will get confused and you will get a little bit like dizzy. Okay? And then hold your breath. And you'll literally be able to hold your breath for almost 3.5, 4 minutes. And you still won't desaturate. And then what gets you hungry again for air is the CO2 coming up again. Okay? So that's a classic, easy test you can show people that it works very well. Hyperventilation. Really, CO2 is really the primary, this mechanism that drives ventilation. Okay? Now, why is that important for us? It's because our job, we give people drugs that impairs their ability to respond to it. Now, ultimately, what I told you was a primary reason that you breathe is not CO2, but it's actually pH. So if I have metabolic acidosis on board, okay, if I'm septic or I'm acidotic for some reason, okay, and I want to hold my breath, it's very difficult for me. That person will begin to ventilate at a more rapid rate and drive their CO2 down lower. Now, as soon as I put this, let's say we put a normal individual to sleep, as soon as you go to sleep, you're not able to remove as much CO2 as you were before. So everybody that goes to sleep becomes slightly hypercarbic. Everybody. Okay? And that's okay. No, you don't really have any deleterious effects. Now, if you were to give you narcotics, okay, that person could slow down their breathing so much so that they develop CO2s up in the 50s, 55 range, and still they're okay. You wake them up, they'll wake up, look at you, and they're breathing fine. But the incentive to drive, the incentive to breathe, the drive mechanism gets suppressed by anesthesia. And you should expect that. If you have somebody under deep anesthesia, you should not expect to see their breathing at 40. There's something wrong. If the person's end-tidal CO2 says 40, and you know that it's a true end-tidal CO2, then either you're not delivering anesthesia to the patient or you have a huge VQ inequality. There's something wrong. That person should be in their 50s. Okay? So one of the things that you have to accept when you let people spontaneously breathe under anesthesia is that all of them are going to be acidotic. Every single patient that you take care of that spontaneously breathes under anesthesia is going to be slightly acidotic. And my answer to that, who cares? Clinically, it makes absolutely no difference in outcomes in the patients. Okay, what it makes a difference is if you have a tight brain. If you have an elevated ICP, then you don't want to let somebody spontaneously breathe. If you have a tumor in the brain, you don't want to let somebody breathe. If you have increased intracochlear pressure, you don't want to let the person spontaneously breathe. If you have somebody with Picquinian syndrome that has CO2 in the 50, 60 range already to start with, guess what? Your CO2 is going to be in the 80s. That's not a good idea either. Okay? The reason being is because they stay at 80, you develop CO2 narcosis, and the person will stay awake. Stay asleep no matter what you do. You could shut off your anesthetic and the person stays asleep. There's no anesthetic on board, and you're going, why don't you wake up? When you look at the CO2, it's 80. The person's going to be completely breathing fine, but it's not going to wake up on you. Okay? Now, the other bad thing is that as CO2 rises, it does two things for you. It vasodilates your lungs and vasodilates your brain. So the lung and the brain are doing the same thing all the time. Okay? And you think about why. The answer is the brain is a primary organ of survival. The rest of the organs can suck it up. Okay? But the brain can't. So if the CO2 elevation goes in the brain has only one answer. Clean me out. Increase my perfusion. So blood flow increases to the brain. So the brain vasodilates in hypercarbia. Okay? The rest of the body, except for the lungs, suffers the consequences. If I'm not getting enough CO2 perfusion to my perfusion to remove my CO2 up here, then I'm going to tell all the organ systems have to suffer. And the way I do that is by increasing vasoconstriction peripherally. So everybody that gets hypercarbic is hypertensive. Every single one. Okay? Proving you to the point, how can I prove that to you? Put a patient under general anesthesia and do a laparoscopic procedure to them. During the laparoscopic gallbladder procedure, you will take the patient and go from flat to severely in reverse Trendelenburg position, which means that their head's up and their legs are down. What should you expect to see when the legs go down below the heart and the head is above the heart? What should you expect to see as their blood pressure? What's that? Right, should drop, right? And everybody that has a laparoscopic cholecystectomy in this country actually gets hypertensive. Everybody. And you go like, and most students when they look at it go like, geez, they got it all wrong in the books. No, okay? What's happening is that you've started a neosynephrine drip. That neosynephrine drip is your CO2. CO2 acts like neosynephrine. It vasoconstricts you to such high degree that you will actually get hypertensive with it, okay? Or even normotensive at minimum. But if you let the CO2 build up too much, you will get hypertensive. Okay, so and that kind of goes against everything else we teach you about reverse Trendelenburg. Okay, but the reason that you make up the difference is that CO2. Now, what's happening to the brain, on the other hand? It's vasodilating. What's the most common complaint of patients post-laparoscopic procedures and post-spontaneously breathing patients? Headache. You get vasodilation in the brain, you get a headache. Okay? All right, not rocket science. Now, if you could put people under deep anesthesia, now they're not going to be CO2 responsive, and you should expect them not to even try to breathe until they hit 50. You shouldn't be surprised. If the person's breathing more than that, then you've got something wrong, and you're doing something not right. Okay? Now, the reason this is all important for you to do is that pain will drive you towards metabolic acidosis in that direction. So if you have somebody with severe pain, they will increase their rate and they'll be responsive more to CO2. Okay? On the other hand, when we give the person more anesthesia and get their pain controlled, you'll see that their respiratory rate will slow down and their CO2 will rise. Okay? And that's what you'd expect. We can actually use that value to titrate the narcotics at the end of the case. Two very, very different ways of thinking. Some people actually very strongly will argue to you that you should never use narcotics at the end of the case. Because if you use narcotics at the end of the case, you can overdose a patient and they'll be apneic and you won't be able to get them to breathe. Okay? And there's other camps, which is what I'm trying to teach you. The other camp tells you that as long as you have somebody spontaneously breathing, you will not get yourself into trouble as long as you give just a little bit at a time of narcotics and see how the person responds. So let's say I'm playing with fentanyl that day. Okay? Fentanyl and morphine are completely different ball games. Morphine doesn't peak right away, so it's not really a good drug to give at the end of a case. The reason it's not a good drug is because it takes 8 to 15 minutes to peak. Even though you're giving it IV, you think, oh, it's an IV drug, it'll peak right away. The difference is morphine is only water soluble. It only has a 6% penetration in the brain every time it swings by the brain. So it takes a little time before it accumulates. Versus fentanyl is very lipid soluble. And within 30 to 60 seconds of administering fentanyl, it's peaked in the brain. Okay? So that's the kind of drug you want. You want something that you can titrate, hits right away, and then it begins to redistribute away from the brain, so levels are falling quickly over time. Versus morphine takes a long time to pick up and then accumulates when you don't need it, and then the person can go apneic and you can get into trouble. So as long as you're not using morphine and not using the water-soluble narcotics, and you're using more the lipid-soluble drugs, you're safe doing this method. What you do is you watch the person's breathing rate. You get them spontaneously breathing at the end. You can leave your volatile on or off, okay, at that point. And you use nitrous oxide, depending on which one you want to use, okay? And then you watch your respiratory rate. If the person is breathing 30 times a minute, that person is way too much pain. And will you extubate them fast? Absolutely. But I can tell you, when you're finished it, they'll be screaming all the way recovery room. Okay? Instead, what we try to teach you is, and several of us will try to teach you that here, is we'll tell you hit it with 25 or 12.5 mics of fentanyl, depending on the age of the patient. Okay? If it's somebody younger, like my age, we'll give them 25 mics of fentanyl at a time. And you'll see the respiratory rate goes from 30, 25. It's not where I want it. I want to target around 20, so I give another 25. And now I'm at 50 mics, and now the person's got their respiratory rate at 20. Then I start shutting off my gases. Usually I start my volatile first, shut that off, and then continue watching them. As the respiratory rate goes back up, It does because the volatiles suppress pain. Okay, so as soon as I shut it off, the person's going to perceive more pain. So what I'm going to do now is I'm going to replace it with a little bit more narcotic, another 25. So now I'm playing this game. I'm actually just watching my voluntory pattern to tell me how this person's going to wake up. Okay? And if you do it right, you can get so good at it that when the surgeon's putting the last staple in, you shut off all the gases, the person's still breathing all the way, so they're breathing by themselves, and then you just tap on the forehead, they open their eyes, and you pull the tube out. It's that cool. It's that rapid of a turnover rate. Okay? The surgeons are amazed because they didn't see anybody bucking. The reason they're not bucking is because you're adding narcotics to keep them comfortable. So even if you put in a staple, they're not going to respond. They're not going to jump off the bed. The most irritant thing at that point is what? It's the endotracheal tube. If you have the person breathing spontaneously and they're not bucking at that time with enough narcotics, they're not going to react to a staple. Now, if the surgeon decides to put a speculum back in the rectum of the patient, which I had one time the surgeon do that, without even telling us, well, that's not going to have a good outcome. Okay? Okay? The guy got covered in it, so it was not a good day. It was actually I was trying not to laugh. I was going like, oh my God, the surgeon's going to lose it, you know. And he just looked at me and says, I should have told you I was going back in. I said, okay. But he was covered in it. Yes? Mm-hmm. I think it's, depending on what you're doing, okay? There's two different things you're doing, okay? One is you're having a patient with high risk of nausea, vomiting, and you'll use propofol for that case with a low pain threshold. The reason I'm saying that is facelifts. Facelifts have so much local anesthetic in their head that they don't even feel their head when they're done, okay? They don't feel anything, okay? So they don't really are lacking in narcotic, okay? Or they don't need anything for pain. What those people need is to wake without vomiting. Okay? So for high-risk patients, we'll switch off the volatile anesthetics and switch over to propofol, which is a pure antiemetic sedation medication. Okay? So when we shut that drug off, the person's really not in any pain. They'll emerge smoothly and be extubated just fine. That's from a different kind of technique because you already dealt with the pain because you injected local. If, on the other hand, you're trying to do this with like a hysterectomy, then you better have narcotic on board when you're taking the Diprivan off, because if you don't, the person's going to scream when they wake up. So it doesn't mask that problem, okay? Unless the surgeon injected a bunch of local in the abdomen, which some of them will do, and that helps a lot, but still the deep visceral pain. If you see the person's breathing 32 times a minute, and you think that when you shut off the propofol, the person's going to be real comfortable, nah, they'll be screaming all the way to recovery room. Okay? Different techniques depend. Which procedure were they doing? Yeah, but they had already interscaling block. See, and the block took away the pain. So that's why you can do it in that method too. Okay, so anything that has local anesthetic and it's working properly, it's perfectly appropriate to use propofol. It's not a problem. Okay, it's just when people are having pain is when I use NARCs. So anything like the facelift, I would have used propofol. Different choice, unless I knew that the surgeon's not really putting enough local in, and the person needs supplemental, or if they're doing something else like laser skin to the skin, it really burns, and then you have to add narcotic because the local doesn't work for the skin sometimes. You'll see the person have, and you'll see when it's not working because when they laser, you see the heart rate goes up. That means that the local underneath is working fine for the facelift, but it's not working on the skin dermatomes. Okay, different nerve centers. Okay, so these are good questions, but you're starting to observe already, and trying to put it all together for you. Okay, so. But these are the kind of questions you want to ask while you're watching. Ask those questions. And people should be able to tell you why they're doing it. Sometimes people will tell you, well, this is the way I do it. Which is what's happening is that person's learned from somebody else who knew why, and they saw it worked, and instead of trying to figure out why it worked, they just adopted it, which is fine. It's called learning from somebody else. Okay? Well, the problem is that you don't know why it works. Okay, and if you have another case where you have somebody with severe pain and you try doing a propofol technique, you're going to get burned. Okay, and that's why you have to understand why you do it in what case. Okay. This is to show you the CO2 response curves that people have that are different. Okay, you will notice that the PaO2 will cause a response that gets enhanced once you get below PaO2 of 60. So, but does that happen only in somebody who's awake and non-narcotized, no anesthesia on board? When you see this effect, this doesn't really occur very much in people under anesthesia, or after coming off anesthesia, they don't respond like this. So this is called a synergistic response. You see this person's breathing the CO2 of 50. That person's going to want to breathe more minute ventilation. You see the alveolar ventilation goes up, yes. But you see once you get close to 60, this increases, which means that's a synergistic effect. Two effects are increasing the effect overall. Okay, so will hypoxemia, as long as you're above 100, will it really affect? The answer is really not. At that point, it's totally CO2 dependent. And what are we at right now when we're weaning somebody off the ventilator? What are we at? What FiO2 are we at? 50 to 100%. So we're way above here. PaO2 should be in the 300, which should be off the scale. So the CO2 is the only thing that they're responding to. They shouldn't be responding to You should never let somebody respond to hypoxia. That's not a good way of getting people to breathe. Okay? Ventilatory response is depressed by sleep, narcotics, genetics differences, racial differences, and personality factors. People that are crazier, in other words, they're like squirrels. This is what's called the squirrel analogy. You ever seen the Over the Hedge? You ever seen that movie, Over the Hedge? There's a character in it that's a squirrel, okay? And the squirrel is so hyper that he's bouncing up and down. And then they give him caffeine, and he distorts time and goes into the future. He goes so fast, okay? Well, that's what squirrels are like, okay? Squirrels are like human beings. If you have a squirrel that you're taking place, I don't care what you do, they're hyper going, let me do this, they're just hyperly talking to you. You put them to sleep, they're going to wake up just that way. You're going to breathe faster than you should expect. So, on the other hand, you have the people that are just like slow, like nothing really bothers them. They're really kind of breathing slower. And guess what? They're going to wake up that way too. Sometimes it's going to be difficult to wake up, okay? I call those the possums. That's my possum analogy. Okay, they appear dead when they're not. Okay, and I'll tell you, you're playing possum on you, and all the numbers are telling you that the person's awake, and they're just going. Okay, and all you should do in that point is you wake up. People make fun of my voice because I drop it down to sergeant level, so I really drop my tone, and people open their eyes. Versus, you guys are just normally speaking to people and going, "Please wake up." I'm like, no, it doesn't work that way. If you're ever under anesthesia, it feels like you're 100 miles away. You can hear the person, but you hear them really far away. So unless it's like tone change, why sergeants speak to you in the military a certain way is because it gets your attention. They know that if you change your tonality down, it becomes more aggressive and more violent, and people are afraid, and people will pay attention. Okay, have you ever seen the Batman movie recently? The newest one? You see how he changes his voice? He drops his tone way down. The reason he's doing that is to induce fear. That's a psychological component to what we do as well. If you cause people to be afraid of you, you will cause them to respond sometimes. And you want them to respond when you want to get them out of trouble, which is wake up. Okay? Not to be shouting in their ears. I had one patient that he was actually totally deaf, or almost 99% deaf. So he would not wake up under any circumstances at all. So we finally, we actually did a compression thing where we actually clapped our hands beside his head. And the clapping caused not the tympanic membrane to move because that was not working. But the bone, he felt it, so we took a little hammer and hit it, the bone, the posterior, and he woke right up. He could hear that. So sometimes people really are difficult to wake up. And the other thing, too, that happens when you're in your circadian rhythm, what's the most difficult time to wake up somebody? Hello? How many of you worked at 2 o'clock in the morning? What the heck's that like? Okay, so 2 o'clock in the morning is about the worst time you have to wake somebody up from general anesthesia. It has nothing to do with the anesthesia. It's that your circadian rhythm, your cortisol levels are crap. At that point, so low that you're not going to want to wake up. So you really are in a bad place. That's why when you take kids and put them to sleep, for an appendectomy at midnight, and then you wake them up at 2 o'clock. Hey, wake up. The kid's sort of sitting there looking at you like, I'm not going to wake up. I'm sleeping. Leave me alone. And you'll stay asleep. Okay? You got to really be like, rub them and tell them, wake up. And they'll wake up and they'll go, can you just leave me alone? And you put them, as soon as you get the tube out, they're back asleep. And they're not being over-narcotized or anything like that. It's just that their circadian rhythm dictates that they breathe and be asleep at that point. Okay? You do get a ventilatory response that's depressed in hypoxic at birth, so patients that are hypoxic born at high altitudes, or patients with cyanotic heart disease. Exercise tests are measurements of lung, has tremendous reserve, so that's good. It's useful to exercise test to basically pick up really minor dysfunctions and to assess disability. Variables that you can measure is workload, respiratory effort, cardiac effort, and you also make gases. And this is actually becoming a big business. You wouldn't think that, why would anybody that looks like this would need any kind of exercise testing? But these people are almost becoming professional athletes. And these people are just run-of-the-mill people now. It used to be just that only professional athletes would do these kind of things. But now you've got people that are interested in doing triathlons, that are run-of-the-mill 40-year-olds that, they're never going to be athletes, but they start doing this and they start going to exercise testing centers to figure out where it is that they optimize and what can they do to improve their capacity to do exercise. And it's actually becoming a pretty good science. It's pretty amazing. So, not that I'm going to get there. I'm going to be too busy doing other things. Dyspnea is a very bad problem, and it's subjective, and that's what makes it very difficult. It's just a sensation of difficulty breathing, and it's really difficult to measure, and depends on, usually demand is exceeding supply. It's really different than tachypnea, because tachypnea can just be a physical sign of increased respiratory rate, as well as hyperpnea, which is increase in minute ventilation. So dyspnea is actually a sensation that the person will have a shortness of breath. Now, if you have somebody who's dyspneic, don't blow them off. It's actually a pretty serious problem. Okay? And a lot of people just sort of go, the person looks okay at rest. What they're telling you is when they walk to the bathroom or walk to go to get the mail, they're getting short of breath. That's real disease, and you need to sort of pay attention. You put these people under anesthesia, they're going to crash on you, unless you know what's causing it. So what we do is we try to look at what's going on. Is it decreased lung compliance? Is it hemodynamic? Is the person getting, are they developing anemia? Had somebody who came in with severe dyspnea one time. This is a number of years ago, and everybody said that she was fine. We drew a blood gas, and her hemoglobin was 4. The reason she was fine was she was in perfect physical shape, ran, marathons all the time, and she was running marathons with a hemoglobin of 4. She had just run a marathon about 2 days before. It's pretty impressive. And I said, "Don't you feel short of breath?" "Yeah, if I was getting short of breath, couldn't do that last 2 miles." It's like, you're an animal. So we figured out what the problem was and got her back on her running exercises. So some people can really do it. But otherwise you have decreased lung compliance. That gives you abnormal chest and wall dynamic mechanics, and responds to reduced ability to respond to ventilatory needs, and they get dyspneic. The other thing, you can have an increased dead space or increased air resistance that causes the impaired gas exchange, which you can usually figure out with blood gases when they're doing stress tests. There's also topographic differences to the lung function. This is things that are important, like VQ, and also important for determining if you have PEs, pulmonary emboluses. So you can usually use radioactive substances as markers. This is a typical VQ scan. Okay, what we do is we get the person to breathe in the ventilatory pattern radioactive material, and then that's not really absorbed. And then you'll look at that scan. Okay, so this is the first part of the test, and then the next part is followed by perfusion. Okay, in this individual, you can see that the lungs adequately ventilating on all surfaces. So that's good. Okay, and then you get the perfusion part of it, which is the second tracer that's injected into the vein, and you'll see it adequately perfusing the whole lung. This is actually a normal VQ scan. Okay, I know all of you have attended somebody's VQ scan, but have you ever seen the results? Okay, this is what the results look like. This is what the radiologist will read. This is totally normal. If you look at this in comparison to that, the blackness is equal in the ventilation, and blackness is equal to VQ, to your perfusion. Now let's look at somebody that's got disease. Look at this one. This one has perfusion that's absent in the right lung completely, but the ventilation is still equal on both sides. So what does this person have? PE. This is the pulmonary embolus. Most emboli go to the right lung because 60% perfusion goes to the right lung. So PEs preferentially go to the right. Okay, so you get this kind of problem. This could also be a right-sided complete lung, severe pneumonia. But usually you would see ventilation abnormalities, so this is mostly just a pure PE. The value of pulmonary function tests, unfortunately, has limited role in clinical practice because it doesn't always diagnose. It is good if you have a diagnosis that you can follow the progression of disease. And it's good kind of testing prior to surgery. It gives you a benchmark, but it can never exclude somebody from tolerating a procedure. Okay? The procedures are dependent on certain risk factors that you're looking at, and also the ability of the person taking care of you. How adept are they at managing your case? If you're doing peripheral surgery, even if you have severe lung disease, even if you do it under general anesthesia, it's considered okay. You tend to survive just fine. It's better to do it in a regional, but even that doesn't show, there's no real study that shows that regional is safer than general anesthesia in somebody who has bad lung impairment. Okay? It isn't. There's no proof either way. Now, do I think it's better under regional? Personally, I think it is. Okay? If I have somebody with bad lungs, I tend to try to use regional if I can. Now, on the other hand, one of the things that I have to understand is that when I put somebody under regional anesthetic, I'm going to have a lot of deleterious effects. I'm going to impair the ventilatory capacity of the abdomen because I'm going to knock out the abdominal muscles. I'm going to also impair the ability for the person to get more fluids. We have to give more fluids, and they may induce them to go into pulmonary edema. So regional anesthesia is not the perfect answer. Okay? What's also important about this is that you cannot exclude people out of surgery just because you have a pulmonary function test. I've had people with absolutely horrible pulmonary function tests, and they underwent the procedure just fine. And other people that had perfectly normal pulmonary function tests, and everything went to bad. Okay? So you cannot differentiate one or the other. Can you tell you that one person's risk factor is higher than the others? Yes. The first thing you always have to do when you look at risk factors is look at the procedure they're having done. If they're having any intra-abdominal or intrathoracic procedure, the risk goes way up. Okay? If they're doing leg surgery or skin surgery, risk is low. Okay? So those things value. As soon as you get into the abdomen, you affect respiratory mechanics. If you get into the chest, worse.